Okay, I have no disclosure for this talk. And I'm going to cover the topics on involve the use of TPE, therapeutic plasma exchange in patients with Guillain-Barré syndromes and CIDP, which is chronic inflammatory demyelinating polyneuropathies. And although multifocal motor neuropathy is not technically demyelinating neuropathies, but since I'm covering immune-mediated demyelinating neuropathy, I just mentioned about multifocal motor neuropathies. And of course, the use of TPE in paraproteinemic neuropathies, where it can cause both demyelinating and axonal forms of neuropathies as well. And just before I end, I just going to talk about the use of TPE in patients with seronegative immune neuropathies. So immune-mediated demyelinating neuropathies are mainly, due to abnormal immune responses against certain antigens that is expressed within the peripheral nerve. And the standard of care involves mainly the use of corticosteroids, immunoglobulins, and also some immunosuppressive drugs, depending on which type of neuropathies that you are referring to. And of course, you have the options of using plasma exchange, which is basically you remove the serums that contains abnormal antibody and replace it with the donor serums. And also the options of immunoabsorptions, where you actually doing more purification works in terms of getting rid of the abnormal antibody in the serum. So how TPE works is basically by removing abnormal pathological antibodies. But of course, we also know that you have other functions. For example, modulation of the B cells and the T cells in the serums, and then you remove certain cytokines and also immunocomplexes. And at the same time, you replace something missing in the serum with some components. And also in real clinical practice, you do see that when you do plasma exchange on patients with immune disorder, you're actually getting them having their B cell and plasma cell more sensitized to immunosuppressing drugs, where you actually can see later on when you treat them with immunosuppressing drug, they become more responsive. And of course, most of us knows about Guillain-Barré syndromes, where it can be either axonal and demyelinating forms of neuropathies, acute neuropathies. The standard treatments involve the use of immunoglobulin and also plasma exchange. So I'm just going to touch on plasma exchange. In this Cochrane review, which included 6 randomized control trials with more than 600 patients, comparing those patients with Guillain-Barré syndrome treated with plasma exchange and also those without treatment. And you can see from here, the median time to recover walking with aids actually 2 weeks faster for those who actually receive plasma exchange, comparing to those who treated conservatively. More importantly is patients who receive plasma exchange, Guillain-Barré syndrome patients who receive plasma exchange do have less dependency on ventilator at 4 weeks, and also they have more likely to regain full muscle functions in a year. However, most of them, some of them actually have a higher rate of relapse with the plasma exchange therapies compared to being recovered on the natural cause. So in terms of the number of plasma exchange in Guillain-Barré syndromes, we normally do 4 to 5 different courses of treatment. But based on this French collaborative studies group that comparing the use of different number of plasma exchange on mild, moderate, and also severe Guillain-Barré syndrome, defined by whether you can run, you can stand, and whether you can be ventilated due to the Guillain-Barré syndrome, you can see that 4 plasma exchange is probably the minimum. But giving them 6 plasma exchange itself does not actually give additional benefits, even when you are ventilated. So this is why I think majority of the practice is we normally will use about 4 to about 5 courses of exchanges for Guillain-Barré syndromes. So what about the efficacy if compared to patients treated with IVIG? In this randomized control trial comparing more than 100 patients in each arm receiving plasma exchange, IVIG, and also plasma exchange followed by IVIG. You can see from here, at the end of 48 weeks, there's no difference at all in terms of the proportion of patients who are able to walk, the proportion of patients on ventilator, and also the proportion of patients with disability. So you can see that if you got a GBS, you treat with IVIG, plasma exchange, or plasma exchange plus IVIG, there's no difference at all in any arms. So where is the role of plasma exchange then? If you were to say that, there's no difference in terms of IVIG, plasma exchange, or even combinations of therapies. So we know that in some form of patients with Guillain-Barré syndrome, they are very refractory. They are rather severe, and majority of them are due to axonal form of severe Guillain-Barré syndromes. So in this group of patients, defined as those with a poor prognosis, where the EGOS score, which is the prognostic score for Guillain-Barré syndrome, actually more than 6, where it represents poor prognosis. So this group of patients, when you treat them with one course of IVIG, they don't normally recover fully. So when you give them a second course of IVIG, is there any different? But from these trials, there was published, I think, a couple of years ago. It shows that there is actually no significant difference in terms of outcome, whether you give 1 or 2 courses of IVIG. But in fact, when you give the second course of IVIG, you actually increase the risk of getting infections and also thromboembolic event. So we do not normally give nowadays 2 courses of IVIG. And we know that steroid itself does not really help in hasten the recovery of Guillain-Barré syndromes. So it leaves us with not many other options in terms of that, especially for those with severe form of Guillain-Barré syndromes. So earlier studies have shown that when you have a severe axonal form of Guillain-Barré syndromes, although this is a very small, non-randomized control trial, that kind of thing. It's not even a control trial, actually, just an observational trial. When you were to treat those patients who was previously treated with IVIG but did not recover, and subsequently when you plasma exchange them, some of them may respond. In fact, in these studies, up to about 60% of them do respond to plasma exchange. And in fact, those that respond, some of them are actually, 3 out of 4 of them are actually axonal form of GBS. Of course, this is a very small study, it's just about 10 patients. And we can't really take this as, something that is going to be a reference for you. But there are some patients, meaning that there are some cases where severe form of Guillain-Barré syndrome with axonal subtypes, you might want to consider plasma exchange if they do not respond to IVIG. Right. So how to use plasma exchange in GBS? So cost and availability of course, it is a concern. I mean, especially when it comes to the cost of the treatment. And when patient fails to respond to IVIG in those with severe prognosis GBS, there's no evidence to give the second course of IVIG. So you might want to consider plasma exchange if the patient still remain, for example, ventilated and still in severe form of disability. But of course, this needs to be further studied and see whether there's actually evidence on that. For rapidly progressive severe axonal GBS, and again, more study will be needed to confirm the use of plasma exchange in this group of patients. All right, so I'm going to move to CIDP, which is a more chronic form of immune neuropathies where they can be relapsing and progressing. As you can see from here, CIDP patients come with very different types of patterns in terms of weakness and also sensory loss. This actually tells you that this condition can be, rather heterogeneous in terms of their clinical presentations, and also it represents the underlying heterogeneity in terms of their underlying pathophysiology. So the standard treatments for CIDP, actually corticosteroid, immunoglobulin, and also plasma exchange. This is what we call a proven effective treatments. And of course, in some of the patients with CIDP, they do somehow respond to immunosuppressive drugs in certain groups of them. And so what about plasma exchange for CIDP? From again, Cochrane's review, randomized control trials on patients with plasma exchange compared to sham therapies in plasma. So treating patients with plasma exchange actually shows that they improve in terms of disability, in terms of impairment, and in fact, when you plasma exchange them, the patient's nerve conduction study in terms of CMAP amplitude actually improve with plasma exchange. But this is rather transient because all the randomized trials shows that after the plasma exchange, patients with CIDP actually deteriorate rather fast. In fact, when they deteriorate, they can deteriorate within 7 to about 14 days. So it is something which is not going to be very sustainable in terms of long-term effect of the treatments using plasma exchange in CIDP. So we also know that there are something called CIDP-like neuropathies. I think for those who attend Dr. Mehta's talk during the lunchtime, he actually mentions about the autoimmune neuropathy, where there is actually antibody against what we call the nodal and also the paranodal antigen. For example, those with neuropathy 155, neuropathy 186, where these are the antibody which is predominantly IgG4, which does not induce complement. So because of that, they do not respond to IVIG treatment. So this group of CIDP-like patients is rather difficult to treat. And in fact, when you look at the response to IVIG, it's just about probably 20%. And also the response to about steroid, just about 50%. Right? So we know that this group of patients contain certain form of antibody which potentially be removed by using plasma exchange and do respond to the treatment. So when we look at these studies that were published, I think a couple of years ago, looking at the response rate of nodopathy patients, which is mainly neuropathy 155, to IVIG, steroids, and also plasma exchange with rituximab, you can see that the response rate to IVIG is about 40%, compared to IVIG, which is just about 13%, which is understandable because IgG4s are forms of neuropathies. But eventually, majority of the treatment will still need to involve the use of B-cell suppressing agent, which is rituximab. But we know that some patients in this kind of condition, autoimmune neuropathy, do respond to plasma exchange. All right. So this is the case studies on one of the patients with neuropathy 155, and so the neuropathy antibody level itself decreases right here when you plasma the patients. So as you plasma the patients, the antibody just are being removed from the body. So when you repeat the antibody levels, you can see that the antibody actually decreased in parallel. And also this reduction in terms of the neuropathy 155 antibody actually go in parallel with a clinical improvement in terms of the patient's condition. And again, on top of that, they also shows improvement in terms of neurophysiological changes. So it shows that some of the patients with neuropathy 155 can respond to plasma exchange if they do not respond to other forms of treatment. So it is something for you to consider. So in a more aggressive form of we call it pan-neuropathin autoimmune neuropathy, where they actually have antibody against both nodal and also paranodal antibodies. And because of that, this patient actually present to you with very severe progressive tetraplegia. So it also involves severe form of cranial nerve neuropathy, autonomic dysfunction, and also respiratory involvement. So these are the antibody that is going to be very, very difficult to treat. And you know that most likely they're not going to respond to conventional treatment. So in these studies, they're actually looking into 8 patients that has got this IgG1 pan-neuropathin antibody, right? They are very rapidly progressive, and majority of them, if you don't treat, they will pass away. So 6 of them actually had plasma exchange, and 3 of them actually show some improvement, but non-sustained. But following the plasma exchange and you treat them with B-cell suppression therapies, they actually improve in terms of the outcome. But of course, 4 of them died, from here because of you use plasma exchange in this kind of conditions where you actually achieve a rapid improvement in terms of the clinical condition while waiting for a next plan of what to do. If, for example, it's severe form of CIDP, you treat with plasma exchange, you get them better. Then only you plan whether this patient actually need further treatment. For example, your rituximab, just to maintain them into remission. So for autoimmune neuropathy, not responsive to IVIG and also steroid, you can consider the use of plasma exchange. And also in some patients that you suspect, pan-neuropathin antibody kind of neuropathies, you can try using plasma exchange. But majority of them are normally for short term because you need a plan later on what to do with the patient, because long-term treatments with with plasma exchange in patients with CIDP can be difficult, for vascular access and also for technical reason. Okay, a little bit on multifocal motor neuropathies. It's actually a progressive forms of multifocal weakness that normally begins in the upper limbs, and they up to 50 to about 80% of them have this anti-GM1 antibody. They are normally responsive to IVIG, but not to other forms of immunosuppressive drugs. So the pathogenicity is rather unclear. It is being thought that it is resemble the AMAN, which is the axonal forms of Guillain-Barré syndromes, where you have a IgG-GM1 antibody that targets your nodal antigen. But due to that, it's supposed to activate complements and also causes complement dependence kind of neuronal degenerations. But when you have this complement involvement, they should normally respond well to plasma exchange, because plasma exchange also remove complement, technically. But in real clinical practice, you don't see that. In fact, you see paradoxical worsening of the multifocal motor neuropathy with a plasma exchange. And this is thought to be due to some form of rebound phenomenon where you disturb the balance between the pathogenic and the non-pathogenic antibody, where you probably remove also the non-pathogenic antibody that could be protective, where due to that reason, it actually cause paradoxical worsening. But this is just a theory behind, where no one actually know what is the real reason. So, but we do know that when you do plasma exchange on patients with multifocal motor neuropathies, the following plasma exchange, you do see that the level of the anti-GM1 antibody actually drops with plasma exchange. But however, it does not translate into clinical improvement. And despite doing plasma exchange with the drop with the reduction of the GM1 antibody, you do see that the CMAP on nerve conduction test will continue to degenerate. So again, it's something which is very difficult to answer, but it doesn't normally work in a patient with multifocal motor neuropathies. So again, how to use plasma exchange in multifocal? There's no evidence. There's no clear benefits. So just a little bit of parapathogenic neuropathies, where you have a patient that have got production of IgA, IgG, or IgM in the body due to majority of them have what we call a MGUS, which is monoclonal gammopathy or undetermined significance. So for those patients that have got IgG or IgA monoclonal gammopathy, and if they have demyelinating neuropathies, we normally treat them the same as CIDP, right? So, but if you have IgM parapathogenic neuropathies, we know that 50% of them do have what we call anti-MAG, which is the myelin-associated glycoprotein antibody, where the deposition of this IgM in the myelin actually causes splitting of the myelin, resulting of the separation of and also widening of the myelin lamina. And because of that, it causes what we call a form of demyelinating neuropathies due to MAG neuropathies, secondary to IgM. And so in this group of patients, the treatments, the treatment with a monoclonal antibody using rituximab itself has been quite controversial. But some of them do show response, and some of them do not show response in terms of the use of rituximab in anti-MAG neuropathies. But what about plasma exchange? So in these studies that looking at the use of plasma exchange in chronic dys'immune peripheral neuropathies, you see that out of the 9 patients that have anti-MAC neuropathies, 66% actually responds to plasma exchange. But however, all of them remains dependent on the plasma exchange, meaning that it's something which is again non-sustained, just like CIDP. When you wash them, they'll come back and you need a further long-term treatment plan following the plasma exchange. Right, POEMs, the therapeutic strategy for POEM is to treat the underlying POEMs conditions. But however, some of the patient comes to you with very rapidly progressing severe demyelinating form of neuropathies where they actually progress into axonal degeneration very, very fast. So in this group of patients, unfortunately, we have no randomized trials to tell you whether you should use or you should not use plasma exchange, but majority of the consensus actually do not recommend the use of plasma exchange due to unfavorable results from plasma exchange. Right. So how to use plasma exchange for paraprotein neuropathies? For IgM, MAC may be beneficial, but it is not sustained. For IgA, IgG, you treat the patient same as CIDP. And for POEMs, there's no evidence. Right. So there's something that we don't know. And we do see some patient that comes to you with autoimmune neuropathies, but we do not know what kind of antibodies they have. And most of the time when you do send ganglioside antibody, when you send nodopathy antibody, you do not find anything. But you know that this group of patients are due to what I call a seronegative immune-mediated neuropathies. So this is a very interesting studies that look into the use of plasma exchange and also immunoabsorption in patients who has paranodal antibody positive and also comparing with paranodal antibody negative patients with neuropathies. So you can see from here, so for those that with paranodal antibody positive, none of them, for those that majority of them receive plasma exchange, but none of them actually was judged to have a good response by the treating clinicians. Meaning that they have some response, they are not being judged to have a good response by the treating clinicians. But as compared to those with paranodal negative patients, 24% of them actually judged to have a good response. So it means that if someone that comes to you, you suspected autoimmune kind of mediated neuropathies, and if you couldn't find the antibody, you probably can try using plasma exchange and see whether they actually respond. But again, this studies is a retrospective studies, and this study is based on, as you can see from here, the judgment by the treating clinician. It's not something which is objective. But of course, being a clinician, you do know that whether your patient improve or your patient don't improve. So in terms of that, of course, we need further study in terms of looking at seronegative autoimmune neuropathies patient, whether they do respond to plasma exchange. But this is just something to tell you that if you have got no clue in some of the patients with some severe form of autoimmune neuropathies, you probably can attempt to use plasma exchange if there's no contraindication. But again, very much to do with clinician judgment rather than evidence-based here. All right, so this Neurofuscin 155 patients that in the STEM studies, if they illustrated why the patients with Neurofuscin 155 do not respond to plasma exchange, because immediately after the plasma exchange or immunoabsorption, you have a rapid drop in terms of the Neurofuscin antibody levels. But within a month, it raises up very, very fast. And because of that, you do not have enough time for the nerve to actually recover. That's why you do not see much response in terms of the treatment using plasma exchange. But eventually, you need some form of treatment for a long-term solution, because plasma exchange is something which is probably most likely going to be temporarily. All right, so how to use plasma exchange for seronegative immune neuropathies? What I said, if you don't know, you try. Probably 25% of them will work. Thank you.